This week we will discuss the endocrine system. We will review a brief assessment of the anatomy and physiology of the endocrine system. We'll talk about specific diseases such as diabetes, diseases that affect the thyroid gland, and the parathyroid gland. With each of those disease processes, we'll talk about a history and physical exam, our additional findings, diagnostics, and screening. When we look at the anatomy and physiology of the endocrine glands, they affect many different areas of the body, such as growth and development and homeostasis. It can also affect metabolism, tissue function, sleep, and mood, as well as it provides the characteristics for both men and women for their sexual function and reproduction. The hypothalamus is the control and relay center. It stores a lot of different hormones, as you can see here on the slide, such as gonadotropin, growth hormone, corticotropin, dopamine, and vasopressin. The pituitary gland is also known as the master gland. It's important for production or storage of specific hormones. For example, antidiuretic hormone is stored and secreted, and it allows for the reabsorption of water, which can affect your blood pressure, can also affect your hydration status. Oxytocin is used for allow of contraction of the uterus during childbirth, and it also helps promote the stimulation of breast milk once the child is born. In the anterior lobe, we have other specific hormones, such as adrenocorticotropic hormone, which is utilized by the adrenal glands for production of hormones. We also have our sex hormones, or the hormones that will help affect the different sexes, such as follicle stimulating hormone, luteinizing hormone. And again, you can have growth hormone, which helps regulate body production. In the adults, it'll affect bone density and muscle mass, as well as fat distribution. And it also helps. The anterior lobe also has the effect on thyroid stimulating hormone, which we'll talk about in more detail. Our thyroid is responsible for making hormones such as T3 and T4, triiodothyronine and thyroxine, respectively. These hormones are regulated based on the iodine intake in our food and converted into these hormones. Our parathyroid is another gland that allows us to regulate bone remodeling and the distribution and redistribution of calcium. Our thymus is responsible primarily for the development of T lymphocytes. The pancreas has two different functions. In the exocrine function, it provides breakdown of our foods. So it produces amylase, which will help break down carbohydrates, lipase, which affects our fat intake, and protease, which helps in protein catabolism. The endocrine function is primarily hormonal, and what it does is it helps regulate insulin and glucagon. In the islets of Langerhans, there are 4 different types of cells. Our A cells produce glucagon, our B cells produce insulin, D cells produce somatostatin, and our F cells and D cells produce pancreatic polypeptides. And we'll note that glucagon is primarily used to stimulate the liver to convert stored glycogen into glucose. When we look at the adrenal glands in the adrenal medulla, it's responsible primarily for the release of adrenaline and noradrenaline, or epi and norepi. In the adrenal cortex, it affects the glucocorticoids and mineralocorticoid steroids. And then, of course, the sex organs themselves, the ovaries help produce estrogen and progesterone, and the testes produce testosterone. There are different types of diabetes. Primarily, most of us are familiar with type 1 and type 2. There's also gestational diabetes for women during pregnancy. And there's other forms of diabetes as well, such as the maturity onset diabetes of the young, rare autosomal dominant inherited conditions, diabetes due to mutations of insulin and insulin receptors, so on and so forth. Type 1 diabetes can be either autoimmune-mediated, immune-mediated, or idiopathic. And our latent autoimmune diabetes of adulthood has a much slower onset of development than those compared with type 1 diabetes diagnosed as a juvenile. Type 2 diabetes is formerly known as an adult onset diabetes. We'll talk about that in more detail as well. Type 1 diabetes used to be referred to as the insulin-dependent diabetes mellitus or the juvenile diabetes. But essentially what we see here is that there's a failure from the pancreas to produce enough insulin. About 95% of these patients have an autoimmune cause where there's destruction of B cells, and the other 5% is idiopathic. It generally occurs in children, young children and teens, but it can occur in any age, and there is a known 25 to 50% concordance with the genetic component. Historically, when you look at your history and physical, these patients are going to have the three Ps, the polyuria, polydipsia, and polyphagia. They're also going to be pretty dry due to the osmotic diuresis that is occurring with the large urine output. They may have unintentional weight loss, blurred vision, weakness. Sometimes it can be precipitated by an illness, most notably by viral illnesses. On your physical exam, again, they may be normal appearing, they may look mildly ill, or they may be very sick, especially if they have components of diabetic ketoacidosis. And these patients can have lots of nausea, vomiting, hypotension, muscle wasting. They have the sweet smelling ketotic breath, as well as the Kussmaul respirations. Type 2 diabetes was formerly known as the non-insulin dependent diabetes mellitus, or the adult onset diabetes. It was predominantly seen in adults, but now with the increase in childhood obesity, we're starting to see it more in children and teens. With type 2 diabetes, you have an insulin resistance, and the body starts to fail to produce the insulin and may progress to a lack of insulin being developed. Peripheral insulin resistance and B cell dysfunction, increased hepatic glucose and lipid production. There is a genetic component to these as well, and it also affects people in certain ethnic groups, such as Asians, certain Indians, and Pacific Islanders. Usually this can be managed by the primary care physician. However, if they are uncontrolled or also a brittle diabetic, they may need to go for an endocrinology consult. And this is the same also for type 1 diabetics. Primary care physicians can, or primary care providers can take care of them, but if they are difficult to control, an endocrine consult is definitely warranted. So when we look at the history and physical, we want to ask for family history. We also want to know if there's any type of cardiac or neuropathic disease, as this is consistent with previously undiagnosed diabetes mellitus. Do they have the three Ps also? Polyuria, polyphagia, polydipsia. Do they have any issues with their vision? Is there any changes in weight loss? Many of these patients with type 2 tend to be a bit overweight, but they can also have an unintentional weight loss, especially if there's some significant issues with the insulin production. On your physical exam, again, some obesity, but more so visceral, not cutaneous obesity. They may have issues with their eyesight, such as retinopathy. Many of these patients have the tall tale or the hallmark sign of acanthosis nigricans, which is the darkening in the folds of the neck, which is pretty typical for those patients with type 2 diabetes. They may have vascular abnormalities, foot ulcers, neuropathies. For looking at diagnostics when you're taking care of patients with diabetes, we have a large arsenal of labs that we can check. First and foremost is the blood sugar. We can look at the complete metabolic profile and take a look at the liver and renal function as well as looking at glucose and electrolytes. Your hemoglobin A1C can let you know the previous few months prior to coming in if there's been an issue with their blood sugar, or if they're diabetic and they're known, you can tell if their control of their diabetes is well within the control of the patient, or if they're not non-compliant and their sugars are much higher than what they're presenting with. Fructosamine is a byproduct of albumin glycation and glucose average for about 1 to 2 weeks. Your C-peptide can let you know about proinsulin, to let you know if there's insulin and the presence of insulin production. And this can help you discriminate between the type 1 and type 2 diabetic. Your oral glucose tolerance test can let you know for those women that are gestational diabetic if they're tolerating the glucose intake. Our serum ketones can let you know if you're entering into a ketotic state or if a patient is transitioning into diabetic ketoacidosis. The beta hydroxybutyrate is a more sensitive test for ketones, and it accounts for about 75% of ketones in the blood, and is utilized in patients once they've been diagnosed with diabetic ketoacidosis as an indicator of management and how well the therapy is improving. Urinalysis is important. Not only does it tell us about our ketones, or a quick test to check for ketones, but we can also see if we're spilling out if we're spilling albumin, and if our sugars are pretty high, you may start spilling sugar into the urine as well. If there's no albumin tested, you can test the urine for microalbumin to see if there's any indicators there as well. And then, of course, we would check lipid panels, as these patients may have maybe at high risk for cardiovascular disease. Laboratory tests that aid in diagnosing diabetes would be the fasting blood sugar with a result greater than 126 milligrams per deciliter. Also, an oral glucose tolerance test, a 2-hour glucose tolerance test with a result of greater than 200 millimeters of mercury. Random blood sugars greater than 200 with the classic symptoms also can include in the diagnostic criteria. If confirmed on 2 occasions, then there's no oral glucose tolerance test needed. Your hemoglobin A1C greater than 6.5% is helpful, but keep in mind that it should not be used as a screening or a diagnostic tool because there can be some inaccuracies. For example, patients that are elderly, African Americans, patients with anemias, hemoglobinopathies, severe hepatic or renal disease may have an inaccurate result and therefore may kind of misguide treatment. For women who are pregnant, they will also get a 2-hour glucose tolerance test, and that's also recommended by the ADA and AACE, and results with a fasting blood sugar greater than 92 milligrams per deciliter, a 1-hour result greater than 100, or a 2-hour result greater than 153 milligrams per deciliter would include inclusion criteria for gestational diabetes. Screening recommendations by the U.S. Preventive Service Task Force recommends checking blood sugars every 3 years in adults ages 40 to 70 and patients that have a BMI greater than 25%. However, if your patient has more risk factors, such as a history of gestational diabetes or polycystic ovarian syndrome, or fit in the ethnic categories that are high risk for diabetes, such as the African Americans, American Indians, Asian Americans, Hispanics, or Latinos, they should also be assessed based on the discretion of the clinician. Pregnant women should be assessed in their first prenatal visit, especially if they're over the age of 45 or have a history or are at risk for diabetes. And they should get an oral glucose tolerance test in the 24 to 28 week assessment. They also recommend any children who are have an elevated BMI or have obesity and additional risk factors, such as having a family history of a first or second degree relative with diabetes. Again, they fit into that high risk ethnic background, have clinical signs of acanthosis nigricans, hypertension, dyslipidemia, or have mothers who have their mother had gestational diabetes during their pregnancy with the child. The thyroid gland is a small ring-shaped gland that sits anterior to the trachea just below the larynx. There's a right and left lobe, as well as an isthmus, which is in the center. The thyroid system in itself is a system which is based on negative feedback. So essentially, the hypothalamus detects levels of T3 and T4, and if they're too low, then they send a signal to stimulate thyroid stimulating hormone, which then triggers more production of T3, T4. T3, T4 is then released into the bloodstream. It causes an increase in metabolism. It is sent to other organs such as the liver, and then as blood comes back to the hypothalamus, if the levels are low, that feedback system continues. Common diseases of the thyroid include hypothyroidism, hyperthyroidism, thyroiditis, and thyroid nodules. Patients with hypothyroidism will be diagnosed as primary or secondary, and your primary patients are the ones that are diagnosed as a congenital diagnosis. Hyperthyroidism can be seen in conditions such as Graves' disease, during pregnancy, or in the postpartum period, or can be induced by certain types of medications. In the acute care setting, those of us that work in the ICU settings, amiodarone is a known drug that can cause inflammation or can cause issues with your thyroid function. Patients who go for interventional radiology or go to cardiac cath may receive an iodine-based contrast. In our small pediatric patients, it can be enough to cause a change or an impact on the thyroid function in itself. Um, Other forms of thyroid disease are thyroiditis, which can be an autoimmune type of response that affects the thyroid gland, such as Hashimoto's. And we can also see patients with benign nodules or malignant tumors in thyroid gland, which we'll talk about here shortly. Hyperthyroidism, it affects about 5% of individuals that are greater than 60 years of age, and it affects almost all their body functions. In women that are pregnant, it is associated with a lower IQ of their children, especially if there's congenital hyperthyroidism. And it could be an irreversible cognitive impairment, which could be devastating to some families. When we do our physical exam and our history taking, we'll notice that these patients generally are known as slow and cold. So they tend to have weakness fatigue, they have cold intolerance, their bowel movements tend to be slower and more constipated. They can have weight gain, depression, as well as when we do a physical exam, we'll notice that the gland can be normal in presentation or it can be enlarged. They tend to have dry skin, brittle nails, their hair tends to be very brittle as well, and they have delayed deep tendon reflexes. And classically, when we look at their lab work, we'll notice that the TSH is elevated with a low T4. And if you go back to the module or the picture that I showed you of the thyroid function and the negative feedback, it kind of makes sense. You have a low serum free T4 and your TSH is being elevated because the hypothalamus is trying to bring up that low free T4. Other labs to check would be a CBC looking for anemia. You could do a CMP looking at hyponatremia, or you can do a lipid panel, which you can look for hyperlipidemia. And again, in this schematic here are these pictures. On the left, you can see the normal function of the thyroid, in which the hypothalamus detects that there's low T4 and T3 in the bloodstream. It then stimulates your TSH to affect the thyroid to allow for more production of those two hormones. Then those hormones are then sent throughout the body, and you can see how the loop continues. In the patient with hypothyroid, there's either not enough T4 or T3 within the system, or the hypothalamus is not recognizing that those levels are there. And then your TSH production is increased in the effort to try to produce more T4 and T3. In primary hyperthyroidism or congenital hyperthyroidism, we have children that are born with a malfunctioning or a dysfunctional thyroid gland. In the state of Florida, we do a newborn screen on all infants that are born within the state, and we test for hypothyroidism. And with early detection, we're able to treat these infants and prevent some of these older or more known congenital hypothyroidism, such as cretinism. The concern is if the thyroid is dysregulated, there can be a very high risk for cognitive abnormalities or developmental delay. As you can see in the far right bottom corner, there's a baby that on the left side of that picture shows a lot of that myxedema, facial swelling with the thickened tongue, mottled skin, and then once the baby is treated, the baby looks more normal afterwards. So again, that newborn screen is very important to make sure, number one, that it's reviewed for hypothyroidism and that it's done initially, especially for those patients that are now born outside of the hospital settings. Adult hypothyroidism, you could see more of changes as the thyroid becomes more dysfunctional. So in this picture here, off to the left, the woman has more of a normal appearance. And then comparing that same woman on the right side, she has more an increase in body habitus. She has swelling to the face. She looks more tired. Her hair and nails are probably more brittle. as well as you can see, manifestations of the myxedema to the face. When we look at patients with hyperthyroidism, we see almost the exact opposite. In these patients, you have an autoantibodies that stimulate thyrotropin receptors, and you have an excess in T3 and T4. And most often, this is related to having Graves' disease or an autoimmune disease that causes this process to happen. Graves' disease is seen more frequently in women, especially between the ages of 20 to 40. And the most common cause is thyrotoxicosis in children. And when we do our history and physical on these patients are complaining about being fast and hot. So they generally tend to complain about being sweaty, being hot all the time. They have an intolerance to the heat. They may have unintentional weight loss, anxiety, palpitations. Patients that are storming may also complain of shortness of breath and chest pain. They'll complain of the looser stools, irritability, and fatigue. On your physical exam, these patients may have a goiter or not, but one of the more telltale signs is the exophthalmos, where the eyes look bugged out. They also may be tachycardic with warm skin. They may have a bit of a tremor to them. And when we look at their lab work, classically we see a low TSH and an elevated free T4 and T3, just the complete opposite of what we saw with the hypothyroidism. Here is a nice picture of a woman with the exophthalmos. She's very thin in nature. And this little cartoon does give you a very good depiction of all the different things you might see with a patient with hyperthyroidism. So thyroiditis, we see as an attack on the thyroid. It can be caused by autoimmune diseases such as Hashimoto's thyroiditis. Again, it can be induced by different drugs such as amiodarone, lithium, iodine, like we mentioned earlier. You can have a subacute thyroiditis, which is thought to be viral in nature. Patients undergoing radiation can have an indirect effect on the thyroid. When we get a history and physical on these patients, there may be a strong family history of thyroiditis or Hashimoto's. They could also have a Turner syndrome. Patients with Hep C are also at risk. When we do our exam, these findings are very consistent with hyper or hypothyroid because, again, the thyroid itself has been attacked. They can have a tender, symmetrical or asymmetrical nodule, or the gland itself can be asymmetrical. It can be edematous. When we do our physical exam of a goiter, this is a nice picture of a goiter on the neck. This doesn't necessarily mean that a patient has hyper or hypothyroidism, because you can have a normal thyroid known as euthyroidism, but just have the goiter there on the neck. Now, I would have suspicion and want further follow-up to make sure, number one, there's no malignancies there, as well as if there's not any different types of nodules that we should be looking for. It definitely indicates that there's a condition present. We just need to find out what the underlying cause is. Patients with iodine deficiency that's not regulated in their diet can have presentation of a goiter. And then the lab and diagnostic testing that we want to do are the normal thyroid tests, such as the TSH, the T3, T4, and free T4. And then we can have ultrasonography done to take a look at the thyroid to see if there's anything there that needs to be addressed as far as treatment or immediately. Here's some more pictures of different types of goiters. Sometimes these goiters can be very apparent. You don't even have to do a physical touch of the goiter to notice that it's there. But some can be a little bit more subtle, and a good physical exam is warranted. When we look at thyroid nodules, these are a common finding on your physical exam. It does affect women more than men. In most cases, it is benign, but when you do find a nodule, you should do a workup to ensure that it is benign and not malignant. You want to check for possibilities of there being symptomatic, or is this an incidental finding? Do they have difficulty feeding, such as dysphagia? And do they have any of these symptoms of hyper or hypothyroidism? So this would prompt you to ask more questions about, is this patient, slow and cold or hot and fast? Or do I need to look up or work up further any type of thyroid issue? On physical exam, you want to palpate the nodules, you want to identify and describe the locations of where they are. Again, your diagnostic labs that you would do would be those that we just talked about with thyroid function. Ultrasound may be helpful in identifying some characteristics of the nodule, as well as needle aspiration. And uh, keep in mind that any nodule greater than 1 centimeter should be suspicious and be made off to referral for further evaluation. Here are some pictures of some nodules here. The identification when describing this to your referral is often very helpful. TSH and free T4 are often your primary or first line testing to screen for any type of thyroid abnormalities. Your reference ranges for your TSH are 0.5 to 4.7, but keep in mind some laboratories may have different ranges, such as 0.3 to 4.5. So when interpreting your results, please look at your ranges to identify whether your patient is out of range. Free T4 tends to be very helpful because it lets you know the total amount that's unbound to protein or the free range. Total T4s, more often than not, are not the most helpful. And when sending someone for referral to, say, endocrinology, they'll want to know what the free T4 is. So your free T4 range is 0.8 to 1.8, and your total T4 is 4.5 to 12.5. Your reference range for your T3 is 800 to 200 nanograms per deciliter for the total T3, and your free T3 is 2.3 to 4.2. Additional lab studies you can do for the thyroid gland are the thyroid peroxidase antibodies, or TPO and TPOAB. These antibodies develop as a result of an autoimmune attack on the thyroid gland, so they're helpful in making diagnosis on those illnesses or diseases such as Hashimoto's thyroiditis or Graves' disease, and that reference range is from 0 to 35 international units per milliliter. Some of the more specialty type of testings may be sent are your thyroglobulin, anti-thyroglobulin antibody, as well as the thyroid stimulating hormone antibodies or thyroid stimulating immunoglobulin assays. Other thyroid diagnostics are ultrasound, evaluates the size and presence of the nodule or the goiter in the neck. There's relatively no contraindications. It's a non-invasive procedure. Depending on where the procedure is performed, it could be quite pricey. But again, there's no preparation and there's very little risk to the patient having the test done. The other studies you could do are radioiodine uptake scanning, which is a nuclear med study. These can be very pricey. They do require that the patient be fasted, and they do an immediate, and then they do delayed images, which could take some time. And then there's no thyroid medication that the patient should be on for about 1 to 6 weeks prior. Now, for some patients, that could be tolerated or maybe not be tolerated. So that should be taken into consideration before performing this exam. It clarifies your thyroid morphology and function. It does increase or decrease uptake as noted. It is contraindicated in women that are pregnant because, again, there's a risk of radiation exposure, and as well as MRI or CT. And your MRI and CT can also use to evaluate the orbits or your eye involvement, one, to ensure that it's Graves' disease and not necessarily a tumor that's sitting behind the eye, causing the exophthalmos. This slide here is a nice little diagram of the different diagnostic testing and summary. This is a very useful tool in the clinical setting. It allows you to identify what your normal ranges are, and it kind of helps differentiate between hyper and hypothyroidism and some of the different things that we talked about, including in our diagnostic criteria. These are little notes and tidbits that I usually keep in a little black book with me while I'm in the clinical setting to kind of use as a quick reference. Endocrine conditions can be that of the parathyroid. The parathyroid sits anterior to the trachea as well. The parathyroid hormone is stimulated by low calcium levels. So what it does is it signals the bones to release calcium to help elevate your serum levels, and allows the kidneys to reabsorb the calcium in the collecting system, and it excretes phosphorus as an exchange. The parathyroid also plays an effect on vitamin D to be converted in the intestines to allow absorption of both calcium and phosphorus. Hyperparathyroidism is seen as an overactivity of the parathyroid gland, so it secretes an inappropriate amount of parathyroid hormone, regardless of what the level of the patient's serum calcium is. So this can lead to conditions such as osteoporosis, bone fractures, renal calculi, peptic ulcers, pancreatitis, and other effects on the nervous system. Whereas hypoparathyroidism is too little parathyroid hormone, and this decrease. Basically, what happens is you get a hypocalcemia and a hyperphosphatemia. When evaluating your diagnostic testing for these conditions, you want to look at the serum parathyroid hormone, which the normal reference range is between 10 to 65 nanograms per liter, or 10 to 65 pgs per ml. Additional testing you could do are vitamin D levels, alk phos, urine calcium, ultrasound, CT, MRI of the neck. This concludes the endocrine lecture. If you have any questions or comments, please send me an email. Thank you.